All right, so this morning I'm excited to introduce Dr. David Paltiel. Dr. Paltiel is a professor in public health management in the Institution for Social and Policy Studies. He's also the co-director of the Public Health Modeling Concentration at Yale University. He holds an MBA and a PhD in operations from Yale University. And his research focuses on promoting reasoned approaches to choices under uncertain and resource-constrained conditions in health and medicine. And he designs and implements model-based cost-effectiveness analyses of medical technologies and public health interventions with a special interest and expertise in HIV/AIDS. He's published broadly on cost-effectiveness of testing, prevention, treatment, and care, both in the United States and around the world. He's been extremely responsive to the COVID-19 pandemic and led a number of important studies, such as developing strategies for reopening college campuses, analyzing vaccine rollout plans, and advocating for more resources for vaccine production and distribution, and performing cost-effectiveness analyses on the use of rapid tests. So we're really excited to have him here with us this morning. So please join me in welcoming him.
Hi, everyone. Thanks for that great introduction, Spencer. Can you hear me and see me? Somebody, yes, okay, good. I'm sorry, I know that nothing will identify me more as an old fart than telling you that I had trouble coming in through Zoom, but I did, and I've had to come in through my browser, and so the user interface looks completely different, so please forgive me as I just try to manage this wild beast, and yes, I am an old man. Can you see a screen? Yes.
Yes.
All right, then maybe I've actually managed it despite myself. All right, I am certainly not going to try. By the way, that opening set of slides and news from Spencer and Becky were worth the price of admission right there. That was great, and thank you so much for permitting me to serve as a fly on the wall while listening to that. That was great. I am not going to try to wow this particular group, which has done so much advanced work, not just with COVID, but in modeling of infectious disease in general. With my great modeling skills, I don't have any. I have simple modeling skills that I apply to policy questions, and I'd like to show you a paper that is hot off the presses. I've put the link to the paper as well as to the supplementary materials into the chat box. I need to acknowledge my co-author, Jason Schwartz, as well as NIDA and several different consortia of university presidents who reached out and asked for guidance with regard to their reopening strategies for this coming year. And it was they who motivated this analysis, notably the Massachusetts Higher Education Testing Group, which is a consortium of 15 different universities and colleges in the Boston area, the Yale University COVID Public Health Committee, and Ed Kaplan, whose work may be familiar to some of you. And by the way, I have about 10 minutes worth of slides. Spencer, I gather that this is pretty freewheeling. I hope people will just feel free to interrupt, veer off. I don't really care if I get through my slides or not. So let's just have a discussion. But as you know, here we go again. Residential colleges throughout the US are again confronting the challenges posed by the pandemic in their planning for operations as the academic year now gets started. And just like in 2020, the characteristic features of campus life, communal living, shared dining, sleeping and bathing spaces, classrooms, performance spaces, athletic venues, and a population of young adults eager to socialize, all raise concerns about super spreading and the safety of neighboring communities. But things are different this year than they were last year. We're certainly presented with a dramatically more favorable vaccination context. We have widespread availability of multiple effective vaccines in the US. In addition, last year's experience demonstrated the considerable benefits of testing, asymptomatic routine testing for SARS-CoV-2, as well as all sorts of non-pharmaceutical interventions, and residential colleges that really did adhere assiduously to a combination of high cadence testing and de-densification, masking, hand washing, social distancing, really do appear to have significantly reduced the transmission of infection on their campuses last year. And this year, of course, depending on where you are. The marginal cost of performing a routine asymptomatic test seems to have been driven down as low as $2 per test. It's not quite that low on our campus, but it's low. And all these observations suggest that the question facing residential colleges this year isn't the same one as last year. Last year, the question was, is there a safe approach to bringing students back onto campus? I think this year, the challenge is, how can we design and implement a portfolio of strategies, some combination of encouraging vaccination and virologic monitoring and non-pharmaceutical interventions that will strike what university decision makers and their stakeholder groups consider to be an appropriate balance between adequate outbreak control on one hand and some sort of restoration of the residential college experience. And so the purpose of our report was simply to provide some evidence and structure to address that challenge, to revisit the analysis that we had conducted a year ago on safe strategies that mostly recommended just high cadence testing, but now to capture our evolving understanding of the problem, notably the shifting epidemiology of infection in the United States, the emergence of variants, what worked on campus, what didn't work, the effectiveness of vaccination. And I need to be very clear right at the outset that this was an analysis that was commissioned by university presidents whose primary duty and interest was the safety of their students, staff, and faculty. Not that they don't care about what's going on in the surrounding community, but they clearly wanted us to focus on the student population, and that's what we did. We focused on the students. We did pay attention to what was going on outside the walls of the campus, but I need to be very clear that this is not an assessment of population-wide strategies for COVID containment. It is strictly an assessment of what goes on in a college setting. I'm talking a million miles an hour. I don't know why. I wish somebody would interrupt because I've only got 2 slides left. In addition to the paper that I circulated, you'll notice that there's also a supplement. It's a companion tool. Because the background conditions and risk tolerance are going to vary so much from one college to the next, we made a spreadsheet implementation of our analysis publicly available. We wanted it to be completely transparent, and Excel, nothing excels better than Excel at helping people to just see and feel what's going on. And so we hope, and certainly from the downloads we've gotten so far, it would appear that people understand that this tool may actually permit decision makers to evaluate the likely impact and interaction of the prevention and screening options at their disposal, to assess the feasibility and compatibility of the choices and objectives that they have set, to explore alternative prevention strategies, and to see how those explorations might vary in the face of the uncertainty. So
David, I have a quick question about that. Yeah. Okay,
Go.
So I'm squinting at that last slide. I'm wondering what exogenous shocks are.
We'll get to it. Do you want me to say it right now?
No, you can get to it later. It's good.
All right, well, let me get to it now. Because we focused so closely on the residential college campus, we wanted to permit the possibility that there would be infections and transmissions onto the campus over and above that which you would typically observe in a standard SEIR framework. And so in addition to everything else, we just allowed additional infections to be imported to campus on a regular basis. You can set the frequency, you can set the magnitude, but it just says, in addition to everything else, what happens if a certain number of infections just happen? And what we were thinking about were experiences that we observed on the Yale campus. One where the hockey team decided to schedule a practice without telling anyone 10 miles north of town at a rink where 18 of them came back with infection. Another instance where a number of students all went out to dinner together and all brought back infections. Just sort of, these were just the idea of sort of additional imported infections over and above that which you would expect to observe in the framework of a standard dynamic transmission model. Good enough?
Yes, that's great.
Okay, I'll move on. So motivating our approach here is the contention that decision makers, whether they be college presidents, university overseers, elected public officials, they express their beliefs and priorities and preferences regarding campus safety via the choices they make on 4 dimensions of decision making: how much vaccine coverage they're going to encourage or require, how frequently they are going to perform routine asymptomatic testing, and whether that testing will be targeted to particular, either to vaccinated or unvaccinated populations or to the whole populations. Third, their tolerance for infections on campus. And finally, where they choose to strike the balance between, on the one hand, complete lockdown safety, and on the other hand, complete return to pre-COVID activities and normalcy. So those are the 4 dimensions of decision making that we offer them in the decision tool. Let's look at them a little more closely. First, vaccination coverage. Rates of vaccination coverage are going to vary very widely across the United States. Colleges that elect not to do anything about it will still probably observe a 50% vaccination coverage.
David,
simply, yeah.
I think there's a question. Sorry to interrupt. Holly, do you want to ask your question now?
Well, I just want to make a comment that this assumes that college officials are able to regulate vaccination coverage. And in our state, we are not allowed to require vaccination for students except athletes.
Right.
They're allowed to require vaccination for athletes, but not other students. And I think that it may be the same situation in Texas. Isn't that correct, Lauren?
Yes, we're not allowed to require, we're not allowed to ask. Yeah, but we can do everything. We can do everything we can to encourage, which is what we're doing.
Got it. And I understand that, and that's why I think I tried to be careful. Maybe I wasn't careful enough in saying decision makers, leaving it somewhat unclear whether those decision makers are in fact the university presidents, the overseers, or the elected officials who simply make that decision on your behalf and in your stead, with or without your consent. By the way, I'm seeing that my video, am I off? Does it matter? There, wait. By the way, I'm in my basement in my ski house in Stowe, Vermont, which is about 30 miles from the Canadian border. So if you're looking at a bunch of ski equipment and wondering what's going on, yeah, that's why it looks like this. Okay, so yes, I do totally appreciate the fact that you may not be in control of how much vaccine coverage you achieve. I am going to lump decision makers in as a large group and say that, if you don't control it, then you need simply to set it rather than having control. But it would be useful still for you to be able to explore what if we could do more to incentivize vaccination. But as I said, colleges that elect to do nothing will nevertheless observe vaccination coverage rates in the rate of, order of sort of 50%, which is sort of, depending on regional particulars. More aggressive approaches, places where you can have mandates and incentives and where exemption policies can be pretty rigid, can lead to vaccination coverage rates in excess of 90%. At Yale, it appears that we've got a student coverage rate of 98% at present and counting. So it's a pretty big variable, but I do appreciate what you said about the fact that this may not be something that necessarily resides within the control of the people sitting on campus so much as it is a number that is imposed upon you. That, of course, will necessitate that you take other measures in order to keep your campus safe, and that's what this tool is designed to help inform. So the second dimension of decision making is the testing frequency. Many colleges chose not to do any testing for asymptomatic infection last year. Others that did may have retired their asymptomatic testing programs and plan only to test for symptomatic individuals this coming year. Others may elect to target screening activities solely to the unvaccinated population, and still others may test members of the campus community regardless of their vaccination status. The decision tool permits you to choose the testing frequency both for unvaccinated and vaccinated individuals, ranging from not at all to daily testing. Third, tolerance for campus infection. It's unrealistic to expect that all viral transmission can be eliminated. A more credible expectation is that the rate or the cumulative number of infections can be held below what individuals, decision makers deem to be a tolerable ceiling. Now, you may balk, and other administrators might also balk at the suggestion that somehow they can, specify an explicit threshold that defines a tolerable level of infection. But one need only look at how widely divergent the responses to outbreaks were on campuses last year to see that this really is a choice. The University of North Carolina, Chapel Hill moved online in the very first weeks of the semester when some 200 students tested positive for the coronavirus. By contrast, the University of Wisconsin-Madison, a similar sized school, remained open for the whole year, despite the fact that more than 900 positive cases were observed in a single week in September, and 7,500 or more cases were observed over the year. Michigan remained open for the entire year, even after 3,000 cases were detected on campus. And we're seeing it again this year. Rice immediately shutting down after turning to online classes on the basis of what I think are turning out to be testing glitches. I don't know if they've reversed that decision. You guys in Texas probably know better than I do about that. Duke appears to have set some campus restrictions after observing a large rise in cases among vaccinated students this past week. But our point here is that it is a choice, and that universities do express something about their preferences and priorities based on their level of infections that they deem to be tolerable. The final dimension of decision making that we specified was this idea of the trade-off between safety and the return to normalcy. What priority the universities want to give to restoring pre-pandemic college experiences. The balance between safety and normalcy can be struck at any point on the continuum. And we defined a different kind of reproductive number here. We gave it the label R star just to make it clear that this wasn't R naught and it wasn't RT. It is, the effective on-campus reproduction number, taking into account the adoption of non-pharmaceutical interventions, but prior to any vaccination or testing interventions. Those get taken care of in those other parts of the decision tool. So it's a little hard to know what number exactly this should be. As you'll see, it plays less of a central role than you might think. But as a way of sort of getting started and getting a handle on it, we just sort of took statewide estimates, which range from 0.5 to 1.5 for the effective reproduction number. And we also took a look at the fact that we've seen reports of reproduction numbers for Delta as high as 7. And we just varied that parameter across that range to see what would happen. And here I've set it at 3. But more than what its exact number is on the horizontal axis, I'm trying to sell to you the idea that there is some degree of control that universities exert over this measure. Obviously, they are, they can't completely ignore the epidemiology of the pandemic in the surrounding community, but the degree to which they adopt de-densification policies or masking policies or online versus in-person classroom policies, they do have the power to move that vertical line to the left and to the right. And so if you take those 4 dimensions of decision making, and particularly the 2 last ones, they define a kind of a green zone where the return to normalcy can be achieved at levels of infections that are deemed to be tolerable. So the decision model then examines whether the vaccination and testing policy choices that you made in steps 1 and 2, or that were made for you in steps 1 and 2, are compatible with that green zone. So what does that mean? Well, deep underneath this, and I have given you the link to the supplement so you can see the mechanics, but this is just a 1-slide peek under the hood. There's a very simple SEIR model. It's a model that captures many of the essential features of the situation facing college decision makers. It's got the epidemiology of the infection. It's got the natural history of illness as defined by either being uninfected, exposed, asymptomatically infected, or having mild to moderate illness. It does include the availability of testing technologies to detect and isolate and contain the presence of infection in the residential college setting. Individuals who have achieved antibody protection, either as the result of prior infection or via vaccination, move into that antibody protected zone in the bottom, the green zone, where they may, and this is again user specified, they may be protected from subsequent infection, or they may also actually protect from transmission onto others. And also, they may also be protected from progression of disease. So there's three kinds of efficacy that we're taking into account here: preventive efficacy, transmission efficacy, and disease progression efficacy. We also account for waning protection over time, using a very simple sort of exponential, waning function, so that you can specify rates of decay for both the preventive and transmission efficacy of antibody protection. And as I described before, we also allow for the possibility of these exogenous or imported shocks. I don't really want to go much more deeply into this, but if there are questions, I realize this is a modeling group and you probably would like to say something about this brutally simple model.